Yes.
Great. I'd like to start by congratulating the organizing committee, in particular Professor Kanan and Professor Benish, for putting this together. I know how useful this effort is for people around the world. I see over 100 participants, and this is on YouTube, and this will be watched. It's a great effort, tremendous effort. Thank you for putting it together, and congratulations for this wonderful neuroanatomy series. Uh, to start my disclosures, the NOVA flow MR that you're familiar with came in our lab, but I have no financial interest in that. And the transonic flow probe, I am a consultant in developing that. Helen of Troy, this picture is on the right upper corner, and it has been famously said that she is the face that launched 1,000 ships. So what can we say about Professor Ghazi Yasargil, the man of the century that we all admire, respect, and wish to emulate? Maybe he didn't launch 1,000 ships, but he certainly launched more than 1,000 thousands, I would say, careers of neurosurgeons that have strived to follow in his footsteps of microsurgery, innovation, and incredible pursuit of questions, a mind that is forever young and curious. You can see the professor who joined in video when we attended the more than 50th anniversary of the first bypass he performed in '67, delivered an absolutely inspiring lecture at the time, which I'm sure everyone remembers. So it's a real treat to be there and to participate in honoring this legend of our field. This is our campus. It's a large campus university with all the colleges, including engineering and medicine. The star here is our building, the Neuropsychiatric Institute. It's an interesting building because when it was built in 1941, it was built to look like the brain with two towers. The right and left tower are the right and left hemispheres connected by the corpus callosum to represent the whole entire spectrum of the neurosciences. We still have our offices and our lab there. It's a tribute to Eric Oldberg, who was the last resident of Harvey Cushing, who put this together when he came to Chicago. He was succeeded by Dr. Oscar Sugar, then Robert Kroll, then my mentor, Dr. James Ausman, and then I succeeded him. This is a view of our building now. The campus is more and more built up. And what's really exciting is just last September of last year, we finally completed this massive laboratory, and the whole entire footprint of the building. It's a $10 million project just for innovation and training. It's called the Surgical Innovation and Training Laboratory. It's a world-class facility, and it is designed to capitalize on our pedigree, going from Harvey Cushing and Halsted all the way to the leaders that have graced this institution. It's a beautiful facility, and the design is to reflect creation and innovation and an open spirit. It's made of various spaces. The central space, the core space, is a traditional learning space with 24 double microsurgical stations, so 48 participants can be there, or we can have 24 tables for cadavers. We have 2 full operating rooms that are better equipped than our operating rooms actually in the hospital. It's all connected to the world through all type of media. The design is by Italian engineers to make it look beautiful. The light can be changed, the walls and the windows can be made opaque with a flip of a switch to separate the areas, so there is so there is privacy between one area and another, but an open space if needed. Our residents love it. This is some of the pictures there. We have natural lighting. You can actually see we have green walls. This is true, alive plants, not artificial, to again bring an ambiance of organic, enlightened approach. Here's our residents. You can see that the happiest place, they're there. They all get a smile in their face, and they're participating in that. And we look forward, once things resume, as far as traveling, to all of you eminent colleagues participate in person in this lab. So the general topics today about flow-guided bypass for aneurysms will follow these bullet points. The first question is, why do we do a bypass? There's, of course, many options. We can do EC, IC, we can do IC, IC, so many variations and things that have to do with the art of it, truly. But why do we actually do a bypass? The nutshell summary of this is that anytime we do a bypass, and for that matter, anytime we take a needle, a microneedle, and we put it in a vessel, we're doing it for one or two reasons, only those two. We're either doing it for flow augmentation, like you see on the left, for the patient, say, who has moya, chronic ischemia, where we want to increase the blood flow to the severely ischemic brain, like the desert, or, which is the topic of today, flow replacement, where we're doing the surgery to correct for a deficit that we create in the course of treating, in this case, the aneurysm. It could be for a tumor or trauma. And of course, the goal of aneurysm treatment is to exclude it from the circulation. And we can exclude it in different ways. We can exclude it directly with clips, coils, or indirectly by proximal vessel occlusion or flow diverters. They all do pretty much the same thing. But we want to do that while preserving flow in the distal branches, plus or minus the parent vessel. So that is the goal of surgery. And if we don't preserve flow, if the flow is compromised, that can be catastrophic. And this is where a bypass comes in handy, in particular for the carotid, the MCA, the ACOM, the PICA, the PCA aneurysms. And this can be also compounded, the need of it is compounded when there is indirect vessel compromise. And we have to always think of that, such as atherosclerosis in the neck that we don't see from the outside, the clip that can kink after we put it, thrombosis because of bleeding from perforators. And the third category, which is very interesting but not very well understood, is adverse hemodynamic consequences. And I'll show you some examples of that. And in order to really progress, not just technically, but mentally, it is really important to quantitatively assess what we do. And this has been a seminal contribution, not in what I did, but into my understanding of becoming a better surgeon, is to study the blood flow and the blood vessels during surgery with a flow probe, which is ultrasound, and perioperatively with an MRI. Now, it's important, as all of you, I'm sure, know, that when we look at flow with angiogram, such as, say, ICG, that does not correlate with flow. So we can have an ICG that goes through a vessel, but the flow is very compromised. Or we can have delayed filling of a vessel from ICG, but the flow is good, because all this ICG is telling us is the time it takes for the dye to travel from the point of injection to the moment we illuminate it with the camera. The diameter does not correlate with flow. I'll talk more about it. Velocity for sure does not correlate with flow. We know that velocity increases, in fact, when there's a stenosis until eventually it stops. And a pulse certainly does not correlate with flow. And the quote here is, beware of the bypass with a great pulse, because that means that the pulse wave is reflecting across an obstruction, and most likely this bypass with thrombose. So at surgery, we can measure it with ultrasonic flow probe, and perioperatively, we can measure it with the SNOVA software, which is quantitative MR angiography, actually does not use contrast. It uses a sequence called phase contrast, but it allows us to measure flow precisely in various vessels in the circulation, in the neck, in the brain, and actually in other parts of the body. And these are blocks that we use to build the perfect surgery. The next block is the cut flow. What is the cut flow? The cut flow is an extremely, extremely useful measure when designing a bypass surgery. It simply means that you take a vessel, a donor, like the STA, and you cut it. And you measure the flow without resistance. And what that will tell the person is how much can this vessel give. This is the maximal carrying capacity of this vessel. So it gives you a very good idea of how much this vessel can provide as far as flow. And that's very useful. And it's important to check it. And for example, here's a case where the cut flow is being measured, and it's found in this beautiful STA to be 9 to 11 cc's, which was very puzzling because it looks like a nice vessel and you think it should be more. And it's a good thing that I checked the cut flow at this point, which is what I do before connecting it or going further or wasting more time. Why? Because the reason this cut flow was low was very simple. The vein, which has been coagulated but not cut, had constricted the artery. So we see that commonly. Some constrictions can reduce the flow. And look what happened. It went from about 10 cc's to 50 cc's. So a simple maneuver increased the flow by about 5 times. And from the cut flow and then the bypass flow, you can calculate the cut flow index. What is the index? Simply is after you do the bypass and you measure the bypass flow, how does it compare to the cut flow? So if you have a bypass of 50 cc's and an STA that can give 100, it's a 50% index. And you have to ask yourself, why is it 50? Why is it not 100? And there's many reasons for that, which we'll go over. But what is important to know that this cut flow index correlates through multiple studies that we published at various times. This is the last one of more than 300 patients with patency. So when you have a good cut flow index, everything went well and the bypass will be patent. So now we get into this very interesting conversation, which I hope we have more logically going on forward, which is the logic of a choice of a bypass conduit. How do we choose a conduit? So you hear these conversations, you hear these words, low flow, and people refer to STA, occipital, high flow, radial artery, vein, and so forth. And just like that, that tells me that the person has confusion on their mind. They're confused because what they are confusing is the name of the vessel with what the flow is, what the carrying capacity in that vessel. They are conflating the diameter with the flow. And I mentioned that to you before, that doesn't usually correlate in vivo. And I'm going to show you example after example after example. So what is then the most important determinant of flow in vivo? And you see in vivo is emphasized in italic. What is it? Well, everybody will then quote the Poiseuille equation, which says that the flow is related to the radius, to the 4th power. So they'll say, what's the diameter? Most important determinant of flow is diameter. The question is in vivo. It's not in tubes, it's not in Poiseuille in the laboratory, it's in vivo. And in vivo, the diameter plays little to no role. I'll repeat it, little to no role. What drives the flow in vivo is the demand, which is the pressure gradient from point A to point B. So when we choose a conduit, we have to keep that in mind. The purpose of choosing a conduit is to secure a flow that is sufficient to replace the deficit that we created. That's as simple as it can get when it comes to bypass for aneurysm. The bypass for aneurysm is an algorithmic procedure. It's a computer algorithm. And you have to balance this flow need with the trauma. You want the least amount of trauma. You want a graft that will live the longest possible. You want to meet the hemodynamic requirement, and you want to do, we heard enough, the enough exposure, you want to do the enough bypass. Don't do more than needed, certainly don't do less than needed. So, but why, Charbel, are you complicating things like that? Why don't we just put a radial artery all the time or a vein graft all the time and be done with it? Well, first, you may not need it. But second of all, there's this thing here. It's a pesky little thing. It's called the wall shear stress. And that wall shear stress will act in a way that if your bypass is of a diameter that's too large, it will occlude if there's not enough flow in it. So it's a waste of surgery, and it's more trauma for the patient when you could have used an STA perhaps and done the job. And this has been shown in many ways, but the paper I like to quote the most is the ELANA experience. And ELANA is the bypass that was devised by Professor Tulikin, and he called it a high flow bypass. As it turned out, it wasn't a high flow bypass. It's a large diameter bypass because they used vein graft all the time. And here's the flow in this large diameter bypass. All these bypasses are 2.7 to 2.9 millimeters. So they're large diameter vein grafts, but not high flow. You can have flow that's high, you can have flow that's low. So does it matter? Yes, it matters because you did a very big surgery, and what they found is that the postoperative patency in the low flow group, in other words, patients did not need that much high flow, they needed less than 40 cc's, and you put a large conduit, it doesn't flow higher because it's a large conduit, and the bypass will occlude, very low patency. So there is a reciprocal relationship between supply and demand. On the left is at 3 days an STA-MCA bypass when the carotid was occluded, and then 3 months later, the carotid recanalized because it was a dissection. The flow in the graft went from 79 to 37 cc's. The graft shrunk, reciprocal relationship, flow and demand. So there are many reasons for bypasses to fail, but for aneurysm surgery, the most common reason outside of technical, which is the most common reason, outside of technical is poor indication, which is a type 1 problem. What is a type 1? This is a type 1. In red is the STA. Flow is measured continuously. So right here, if you see my cursor, the flow in the STA towards the left is about 5 to 7 cc's. That's the artery in the scalp. Cut that artery, this is the cut flow, and that same vessel with the same diameter went from 5 cc's to almost 65 cc's or more than 10, 12 times the flow in the same diameter vessel. So the diameter is not what drives the flow in vivo. It is the demand. And once you connect it here, after a bypass is done, the flow is not high. This patient did not need a bypass. It's a type 1 problem. So the bypass for aneurysm is a flow replacement algorithm that is designed to correct for a deficit that we create in the course of treating the aneurysm. It's like a mantra. So the whole surgery is centered around calculating the deficit. So here's a case of this type of aneurysm. The flow is measured on the M1 because we want to trap the carotid, and we see if it changes. If it doesn't change, you don't even need a bypass. It does change from 70 to 50. So the deficit is 20 cc's. So we check the STA cut flow. The cut flow is 44. That's all we need. We obviously do not need a radial artery. We don't need anything more than that. And there's no way to know if you don't measure this deficit. You can guess, but you could be wrong and you could be right. So we do the bypass, and after the bypass is performed, we're going to measure flow again. And this is where it becomes even more interesting, because the bypass, before creating the demand, before clipping the ICA, has only 4 cc's of flow in it. But when the demand is created by clipping the ICA, the flow in the bypass is 24, which is the deficit that we calculated previously. So it's a flow replacement surgery. So here's another one. This is an aneurysm at the junction of the P1, P2, and PCOM in a young person. We're prepared for everything. We're prepared for a vein graft. We're prepared to go to the neck, but we also have an STA here. And what if the STA insufficient? It would be the best operation for anybody of any age, young or old. So it's a left pretemporal approach. You've heard this approach before. Third nerve Here's the carotid, the PCOM, and the junction P1, P2, PCOM aneurysm. We need to replace the PCA. How much flow is in the PCA? 16. We check the STA cut flow, 39. Do we need the radial artery? No. Do we need a vein graft? No. We don't need anything but this STA. It's plenty. We have a proof. So we go ahead, we do the anastomosis at the P2 segment right here, right at the third nerve level. And the flow in the bypass is only 5 cc's. What went wrong? Nothing went wrong. The only thing is that there's no demand yet. And when we trap the aneurysm and create the demand, look at the flow in the bypass. It's now up to 22, 23 cc's. It's going to increase over time. Here's the angiogram, STA to PCA. And over time, it's now 70 cc's. It continues to mature. Why? Because it's an alive vessel. It's an STA. It can accommodate and increase over time. Another example of an M2. For sure, radial artery or something like that. Well, maybe not. How much flow do we need to replace? We need to replace, we measure it before surgery, about 100 cc's. Okay, so 100 cc's. What if her STA can suffice? Well, lucky for us and her STA cut flow was sufficient. So the STA replaced one M2, the aneurysm is trapped, and here's the other M2 from the M1. And the flow, remember we said we wanted 100 cc's, post-op flow measurement with the MR, 126 cc's, exact flow replacement. Well, even more, how about now we have a giant aneurysm. The whole M1 is an aneurysm that for sure needs maybe a radial artery or a vein graft, quote unquote high flow. Nonsense. You don't know what flow you need until you measure it. So here it is. Actually, we needed 66 cc's. That's all that was coming out of the 3 MCA branches. And the graft flow was sufficient. It was 62. That's all we needed. Simple surgery. Here's another one. That's a carotid terminus aneurysm. It's a giant aneurysm with hemorrhage and with a lot of coils and with 2 pipeline stents and more coils, and it's a disaster. So we cannot clip it anymore, have to trap this. We need to replace the M1 flow. How much? 99 cc's. Could be the STA, maybe not. We have to be prepared. But if the STA is good, that's all we need. We measured the M1 flow at surgery, 65. The STA is almost 90. We are sure that the STA is sufficient. So go ahead, STA graft, trap the aneurysm. The flow before the M1 is trapping is only 18 cc's. This is the same vessel, right? The diameter has not changed. Create the demand, 75 cc's. And the index of 88%. Here's the NOVA flow afterwards. How much flow in the bypass? You can see it here, 94 cc's in the graft. So flow replacement again and again. Here's a gentleman with seizures. Here's this aneurysm. This was a live surgery course in Padua. 8 months later, look at the aneurysm. Wow, giant M1 aneurysm. For sure, we need a quote-unquote high flow. Let's prepare a radial artery or something like that. Maybe. But how much flow do you think we need for this? We can measure it. We will know. So we measured the flow in the M1 before surgery. Here it is. We're measuring in the M1. It's only 32 cc's. This is an excellent chance that a STA would suffice. And in fact, it did. So I did an STA-MCA bypass, and then the endovascular colleague put a coil in the M1, occluded it proximally, worked perfectly well. 3 years later, the aneurysm disappeared. You see the bypass, it resolved. And how much flow is in this bypass? Only 18 cc's. Here's the bypass. It looks good, but only 18 cc's. Is that a problem? Of course it's not a problem. Why? Because look where the flow is coming from. The ACA, the A2, has 116 cc's. So he has a little bit of bypass flow, but a lot of PO collateral, and that's all he needed. Another example, here's an MCA with a branch that comes right off the dome of the aneurysm. Again, you can do something very simple. Bypass to this branch, like you see here, bypass to that branch, and then clip the rest of the aneurysm. And here's the flow in the MCA after the bypass, it's 120. The right MCA is 183, so it's lower. And in fact, the left should be higher. Is that a problem? No, it's not a problem. How do we know for sure? Well, first we measured flow at surgery, But also after surgery, look at the ACA2, 70 on the right, 112 on the left. So that's PL collateral that's going to the MCA. And also we have 35, 36 cc's in the bypass. So this gives us the full assurance that what we did is the right thing. Similar, those are the aneurysms that are not possible to clip perfectly. You can clip them, but imperfectly. So what can be done here is to transform it into a 2-vessel aneurysm rather than 3-vessel aneurysm. And the way it's done, you bypass to one branch, and then you clip the other one. Now, can you do IC-IC bypass? Yes, you can. But I would argue that this is safer surgery. IC-IC bypass will risk 2 vessels being occluded. If something goes wrong, here you lose 1 vessel, with the other one you lose 2 vessels. And don't tell me that nothing will ever go wrong. That's just not humanly possible. So this is the flow replacement. So this becomes routine. Once you get into this mindset and you have complex aneurysms, you go ahead, you prepare for everything, STA, a larger conduit if needed, and you get ready, you expose. Here I was able to clip the aneurysm. See, the aneurysm is clipped, and the bypass will involute because there's no demand. So after saying all that and touted the virtues of an STA, is there a role for large diameter conduit bypass? Remember, I didn't say high flow because STA can be high flow or low flow. Large conduit, do we ever use it? Do we ever need to use a large diameter conduit? Yeah, sometimes we can. So here's an example. This man presents with this aneurysm, cavernous, treated with proximal occlusion of the carotid. And you see the flow now comes very nicely, tolerated occlusion through the PCOM. And then 4 years later, presents with subarachnoid hemorrhage from a dissecting aneurysms of the P1. See the whole P1 now dissected. So it was like that. Why did that happen? Because the flow in the basilar went from 289 cc's to now 895 cc's. Remember the wall shear stress? This vessel didn't dilate. What dilated? This vessel here. So the P1 dilated, dissected because it couldn't handle it, and this dissecting ruptured aneurysm occurred. Now we have to replace not only the MCA circulation, the ACA circulation, and the PCA. So a very large flow bypass was needed. The STA was not sufficient. The cut flow was not sufficient. Of course, we use a vein graft, a large conduit to accommodate this type of flow. And here's the angiogram. So we're filling the whole hemisphere, including the PCA. What other scenario? This is similar, actually, but this is worse because this is now an 81-year-old that has this problem, but on both sides. So she has this massive symmetrical subarachnoid hemorrhage. We cannot tell which side ruptured, and she has bilateral dissecting PCOM aneurysms. Why is that? Why did her PCOMs dissect on both sides? Because she has bilateral vertebral artery occlusions. So now the flow from her posterior circulation is coming from the anterior circulations through the PCOM, high flow, high wall shear stress. One of them ruptured. Of course, we have to treat both of them because we don't know which. How are we going to do that? So what we did, you can see how the circulation posteriorly is filled from the PCOMs, both PCOMs. So in this case, a large conduit was placed for 2 reasons. 1, her STA was not good. But 2, even if her STA was good, whenever we have subarachnoid hemorrhage, we use a large conduit. Remember, I'm not saying large flow, large conduit, because if this patient has vasospasm, this is the way we're going to be able to get there and treat the vasospasm. If you put an STA, you can't do that. Radial artery, you can't do that either. So large conduit with a vein graft to the PCA, ECA to PCA, trap the PCOM on the right side. Here's the angiogram. ECA to PCA bypass, ECA to PCA bypass. Good flow, 95 cc's, which is more than sufficient to replace the PCAs bilaterally. And then endovascularly occlude the other PCOM. So this was all done in one day and treated both of them and took care of the problem. Now, if this case does not convince you of what is the most important determinant of flow, nothing will. So look at this patient here that's getting a vein graft to the MCA to treat a large aneurysm. I will pause here for a second. What is the diameter of this graft? You just saw it. 1, 2, 3, 4, 5, 6, 7, 8 millimeters. You cannot find a larger conduit diameter than this. And everybody will say this is high flow. Okay, study this with me, if you will. So it's an 8 millimeter large diameter conduit. Is it high flow? Is it low flow? I'll remind you of the question. What is the determinant of flow in vivo? So let's look at it. So here it is. The anastomosis is being done. One side is done. We're going to do the other side. Very large conduit. Okay, and here the bypass is completed. So it goes from the neck, from the carotid, all the way up to the M2, M3. I don't remember if it was an M2 and M3. Huge vessel. How much flow is in it? 24 cc's. 24 cc's, right? Wow. Why is that? Well, because there is no demand. The carotid is still open. The flow is 24 cc's. It stops with every. So I narrow the carotid. I narrow it with a clip. It doubles. Now it's 54 cc's. More demand. More demand because less flow in the carotid. Now I occlude the carotid proximally. Occlude it proximally. Complete carotid sectionized proximally. And then distally. And what's going to happen to the flow now? It doubles again. Now it's almost 83. It's almost 100 cc's. It keeps increasing during the surgery. And eventually what this patient has is this. Here's the vein graft. It's a large conduit. And actually it is also high flow. But it wasn't high flow. It went from 24 to 161, the exact same vessel. Why? Delta P. So what else is useful? Look at this. A junctional aneurysm at the carotid M1, M2 bifurcation, carotid M1 division. We don't see the A1. So I put a graft there and the aneurysm disappeared. Just like that. This is not an artifact. The aneurysm disappeared. So actually, this is a flow diverter. I didn't do anything. I didn't touch the aneurysm. So by the time I went back to angio to see what we're going to do with this aneurysm, it had disappeared. How about this one? We can use this exact phenomenon to treat this aneurysm, a giant, very difficult problem, giant dolichoectatic aneurysm. So here's the basilar flow before the bypass. You see the carotid, the tall one, the basilar, they're in sync. The sinus, phase shifted 180 degrees. After the bypass, you see how the flow in the basilar artery has dampened. It's a bypass to the PCA. It's a large conduit with the intention of high flow to the PCA. Did it work? Yes. Same phenomenon. 6 months later, the aneurysm has thrombosed. Years later, the aneurysm remains thrombosed. It is large conduit and it is high flow, 182 cc's. But it was not high flow unless you create a demand. And this is the last case because this is the best bypass. Subarachnoid hemorrhage, endocarditis. Here's the appearance at surgery. You can see the thrombus. You can see there's a branch missing. You see the aneurysm here with the branch coming out of it. Aneurysm, mycotic aneurysm, branch coming out of it. Have to cut this branch and re-implant it to keep it open. Okay, so let's check the flow. 3.8 cc's in this branch. I wasn't willing to sacrifice it because it could be an important branch. So I cut it to reimplant it. I remove the clip and I look at the backflow. And while letting it loose, actually Bart van der Zwaan taught me this idea. I checked the flow. It was 3.8 forward. Now it's minus 3.3 backwards. This is how you can check if there's collateral circulation, not the ICG. ICG is not quantitative. And all I needed to do here is just clip that aneurysm. There was enough backflow and then clip the aneurysm. So to summarize, we talked about why perform a bypass. For aneurysms, it's to replace flow. What is the most important determinant of flow in vivo? It's not the diameter, it's the demand. So you have to construct your bypass appropriately. The quantitative flow measurement is essential. Measuring the cut flow tells you if the STA is going to be sufficient to replace the deficit. The index gives you an idea of the viability of the bypass. You choose the conduit to perform the simplest surgery with the simplest trauma with the highest degree of safety. A bypass will fail, it has no demand, and you've seen some examples. So to summarize again with an ending homage to the father of microsurgery, October 30, 1967. In fact, October 30 is my birthday. So it's interesting that I'm interested in bypass. It's a fantastic surgery. We all love it. We all do it. It's such a beautiful surgery. It's technically very rewarding, but the microsurgical skills are a means to an end. It is technique based, but it's the thought process that is the end, which is physiology based. So it was wonderful being with you, and I'm so glad to have been able to share the podium with such a fantastic group of colleagues.
Professor Charbel, thank you very much for this amazing talk. This is one of the best talk on revascularization I have ever seen, and congratulations, because all these nuance regarding the flow are, I guess, many times overlooked. I don't know whether there is any question from the panelists or the audience. Difficult to discuss or, or be against your opinion after such a wonderful talk and large experience, Fady.
Thank you. Thank you, Miguel. Appreciate it. Coming from you means a lot for sure.
Thank you. I have one question. Maybe you are doing also revascularization techniques for pathologies different from vascular problems, tumors and things like that. Is that correct? And the
Yes.
question is, just in that case, do you use this? You need to make the same consideration regarding the flow for revascularization in cases of tumor removal, extreme cases, if I may say, at the cavernous sinus, very,
Yeah.
very easy
Yeah,
operation.
absolutely. I mean, the cases where I see myself still doing a revascularization are those massive medial clinoidal meningiomas that encase the carotid, and there's a risk appearance on the angiogram that maybe the carotid or the MCA wall is eroded, and as we dissect, we can get into it. So definitely in this case, a flow replacement bypass is the same algorithm. We check the flow in the MCA, we check the STA cut flow, we preserve it, and see if it's enough to replace. The problem with those bypasses is while it will protect against loss of a large vessel, such as an MCA and ACA carotid, the problems sometimes still occur of a deficit because we cannot replace the flow in a perforator. So if we lose a perforator in an M1 and things like that, the bypass will not save us. But many times it has saved the patient if it's a large vessel or even a small vessel, an M2 branch or even a cortical branch. Why sacrifice it if it can be replaced?
Thank you very much, Professor Charbel. Congratulations again. I don't know whether there is any other comment or question. We are just almost 1 hour behind a schedule, and if the chairman,
I have a question to Fady. Fady, as usual, always enjoy your talk. A question:
Likewise.
over time, you have noticed that there is a lot of good flow that comes from the MCA, from the STA, and less use of the high flow bypasses. As time goes on, how often now are you using a high flow bypass?
So again, I think you mean large conduit bypass, large
Yes.
diameter.
Yes.
The use of a larger diameter, like a vein or a radial artery, has become very, very, very rare. The absolute 100% indication is a bypass in the context of subarachnoid hemorrhage, where even though we don't need the diameter for flow reason, we need it as a conduit to treat. Other than that, it's very, very rare in the cranium, because as you stated, Ali, the STA can do a lot of flow, and the larger the aneurysm, the more actually PO collateral there is, and less flow needs to be replaced. Something we only learned over time. I know you measure flow. By measuring flow, that's what we learned. Where I still use a larger conduit, say a vein graft, is in the neck. So there's a lot of other bypasses that we do in the neck, carotid to vertebral, vertebral to or carotid to carotid, and so forth. And this is, of course, where for matching purposes, and because we don't have an STA in the neck, that would be where we use it. But it's very, very rare now. I would say less than maybe, certainly less than 5 a year where I would use a large conduit graft.
Yeah, because I have noticed since we discussed
Same.
it before, yes, since I have been using the flow meter and checking the flow when I want to sacrifice a large artery, I noticed I'm using it less and less. Yeah.